Good evening, everyone, and welcome to this edition of Woo You Virtual Cortex Training, a new treatment option to optimize the vision for stable keratoconus patients with Jordan Dow, OD. Thank you so much for joining us. Thank you for making Woo You a part of your Monday evening. And I am Dr. Elise Kramer and currently in Miami. Where are you joining us from, Dr. Dow?
I am in Jacksonville, Florida.
Awesome. You can hit the next slide
Okay.
and the next one. Thank you to Revital Vision for exhibiting at this event. Next slide. So this is a 1 hour CE course. So for each hour of CE units, you must be online for a minimum of 50 minutes in order to get your CE credit. For a COPE certificate, please fill out the survey link in the chat. You'll also see that link appear toward the end of the webinar. CE certificates will be delivered by email and sent to ARBO with OE tracker numbers. There will not be a QR code at the end of this event, but you will get your CE certificate via email within 4 weeks. You can ask questions using the Zoom on-screen floating panel that you see circled here. The chat we're going to try to keep for more logistics questions, but if you have questions for our speaker, Dr. Dow, tonight, you can put them in the Q&A, and if time allows, we'll be able to go through a few questions toward the end of the presentation. Next slide. If you're using the mobile version tonight, you'll see that Q&A there at the top, questions for our speaker. But if you want to ask something through the chat, you'll have to click on those three white dots at the bottom, which will give you more options. Next slide. So I will introduce our wonderful speaker tonight, originally from Nebraska and starting out as an engineer. Dr. Jordan Dow switched to optometry and graduated from Southern College of Optometry in 2015. Initially working in a variety of patient care settings, he opened his own practice in 2017, just outside of Jacksonville, Florida. As a cold start, he built Dow Family Eye Care from the ground up and separated himself by focusing on technology and high quality comprehensive exams, and has become known for offering specialty services, including myopia management, various binocular vision treatments, advanced dry eye therapies, and other newer technologies to the market. In April 2025, he opened a second location, also a cold start. Wow, you are brave. And is building that location to offer even more diversified services to his patients. He also serves as the local Vision Source Administrator of Northeast Florida, has been a KOL who does public speaking and personal consulting for multiple companies, including Cooper Vision, Launchpad, and NeuroLens, is the principal investigator for multiple different research projects that Dow Family Eye Care is a site, and is part of the local AOA board, NEFOS. In 2025, founded Specialized Consulting in 2025 to help practices launch specialty services in their practice. When not working, Dr. Dow has two beautiful girls and spends every moment he can with them. Wow, you sound busy.
Oof, that was a lot. That was a lot.
I'll let you take it from here, but I will be on later for questions.
All right, thank you so much, Dr. Kramer. Here are my financial disclosures. And they've been mitigated. And so, really, I know that was just a big old talk about me, but just want to again thank you all for joining me, and hopefully we can learn something today. I did graduate from Southern College of Optometry in 2015. Do now have two cold start private practices. The most recent opened up just a few months ago, and really, I am honestly just a general private practice optometrist. I see my patients every single day, and we have been fortunate enough to focus on different specialties in technology in a few different fields. And so a lot of practical application to everything that we see and talk about. And so these are the two girls I mentioned. One of them is more photogenic than the other, but love spending every moment I can with them. So today we're going to be talking about keratoconus and how perceptual learning can give us another chance to help patients in a little bit of a different way. This isn't going to be a talk about everything about keratoconus because I know we've had a lot of those talks in the past. We all know about the signs and how to diagnose and things like that. But I do want to do a little bit of a background on keratoconus and the important parts about how it affects what we're talking about today. Of course, keratoconus, eye disease characterized by a corneal ectasia where the cornea is steepening, K readings are going up, and we get a cone-like appearance that results in distortion in the cornea, basically giving us an irregular astigmatism. High prescription, high myopia, high astigmatism are very common in patients with this. that really can have a big impact on their visual quality. And lots of different causes that contribute to this, genetics, trauma, different conditions, both on the eye and connective tissue disorders. One I want to focus on is that chronic eye rubbing, sensitive eyes. There are a lot of keratoconic patients that are basically people who've had sensitive eyes, allergies, a lot of times attributed to this, where they're just rubbing their eyes constantly, and that's been shown to cause a deterioration and thinning to the cornea. And so there's a lot of patients who have keratoconus that just also have sensitive eyes, which does impact how we manage and treat these patients. It is a condition that's, relatively common. We're not going to see it every single day in a typical practice, but you are going to have more likely more than a few patients in your practice with it. About 1 in 700 worldwide. In the United States, about 2,000, 1 in 2,000. We know the demographics that keratoconus is typically found in, usually younger individuals. Typically onset at 15 years or a little bit older. These are a lot of patients in their early mid 20s. Progression is variable. Sometimes it goes early, sometimes it goes a long time. There are some different, demographics that we expect it to be in, African Americans, Hispanic, and more common in females as well. And so these are a little bit different than a lot of the other ocular diseases that we are typically managing on a day-to-day basis because it's a little bit different demographics. But again, keep in mind these are younger patients in their mid-20s. So patients with severe keratoconus typically have pretty significant visual symptoms. Of course, we have blurred vision, reduced best corrected visual acuity because of that irregular astigmatism. That distortion in the cornea creates a lot of distortion in the rest of their vision. These are patients that, even if they have a relatively good visual acuity, can complain about light sensitivity, night vision, and just poor quality of vision, saying they can't see, even if we can get their acuity down to a better place. And so it is a bit of a frustrating situation for these patients. These patients can have a lot of different variability in what their symptoms are and what their findings are. They can get scarring if it's gotten severe enough. Their prescriptions are going to change very frequently, sometimes multiple times, a year, a month. There's a lot of variation, and again, very frustrating for these patients. They can have diplopia, a lot of times monocular, depending on the shape of the cornea, because there is an asymmetry in a lot of cases of keratoconus. And because of that asymmetry, a lot of patients have difficulty with binocular vision and stereo acuity. In fact, 75% of patients with keratoconus also have poor depth perception, and the severity varies with the severity of the keratoconus. So, one thing we don't normally think about is how these visual symptoms actually impact our patients' lifestyles. And so many patients with keratoconus actually suffer emotionally, psychologically, and have a lot lower quality of life. Many times getting depressive disorders, anxiety. Um, and yet it's a unique thing because a lot of these other ocular diseases that a lot of times we'll see in our patients, glaucoma, macular degeneration, diabetic retinopathy, a lot of these will have patients that have significantly reduced visual acuities, and keratoconus patients actually have on the average, a little bit better visual acuity than a lot of these. And yet they have a worse quality of life score and mental health outcomes than all patients with these other diseases. And a lot of times that can be contributed to a few things. Number one, it's reduced contrast sensitivity, more visual distortion that can have more of an impact to their life, even more so than their acuity itself. Also, remember these patients have sensitive eyes. And, we're jumping ahead a little bit, but a lot of the treatments that we have for these patients is contact lenses. And so if a patient already has sensitive eyes, a lot of times fitting in with contact lenses can be a very, very stressful thing. And of course, remember the age demographics. These are patients that are in their mid-20s. They are finishing up school, they're starting careers, they're starting families, and this keratoconus can be having a massive impact on their confidence and ability to do things in their life, just as they're trying to get their lives going. And so we have studies out there that will show that patients with keratoconus, about 63% are going to have anxiety, and 56%, over half, have some sort of depression. These studies range quite a bit, anywhere from 41 to 87% of patients, though, with the depression are actually classified as moderate to severe. These are not mildly depressed patients. And what's interesting is some of the more high end of the depression range are actually found in the patients that are wearing contact lenses in both eyes. And lower scores in vision-related quality of life testing, mental health, social function, lower energy, fatigue, even when the acuity was spared, even when the acuity was something that we would normally deem acceptable, they are still getting these lower quality of life, again, because of their eye sensitivity, the frustrations in how they're living their lives, and the age demographics that we're working with. And so this is something that I think we overlook quite a bit, and this is something that we want to be keeping in mind. How can we make our patients' lives better? Again, pointing out that a lot of these patients with the worst depression actually are the ones that are already wearing contacts in both eyes. And so, briefly going into how we manage our patients nowadays with keratoconus. At the low end of the spectrum, conventional glasses. Patient has a high prescription, high astigmatism, high myopia. We can give them a full refraction in their glasses, and as long as they're on the milder range of the refraction, we can typically fully correct them to 20/20 because the corneal astigmatism is usually pretty modest. They do typically have higher order aberrations. They are still going to have some glare and light sensitivity. They are going to have some contrast sensitivity issues because of the shape of the cornea. However, we can address these with some types of lenses where they can be better at addressing the higher order aberrations. Sometimes those can be a little more expensive for patients, but there are options out there just for spectacle lenses to help patients as long as they're in the mild range. I don't think these glasses are going to be the ones that are going to help them out, but there's a lot of creativity out there. Soft contact lenses, again, for the early stages of keratoconus, these can be a very functional alternative to glasses. Patients want to have a little more freedom in their lifestyle, especially with these higher prescriptions where they're very dependent on their glasses. Having the contacts can give them a sort of freedom. However, it's only on the low end of the refractive range. Once the corneal distortion gets to the point where they're -2, -3, -4 in astigmatism, your contact lens options become limited. Your comfort on the contact lenses become more difficult to endure. And once again, pointing back to the patients that have keratoconus, many of them already have sensitive eyes. And so a lot of times these that are going into the soft contact lenses are fighting a losing battle. When we're talking about the non-conventional or the specialty contact lenses, of course, RGPs, the gas permeable lenses, obviously they have a hard surface. They're a lot smoother, and we're basically vaulting over the distortion in the cornea, so that we can actually correct the prescription. Typically, these patients are going to have a lot sharper vision. They are going to be a lot more consistent in their vision because any distortions they have in the cornea are basically getting covered up by the RGP. Variations, on this, the Rose K lenses that are designed for keratoconus specifically, and this is a picture right here of a Rose K lens and how it's trying to basically contain the cone shape from the corneal ectasia. We can do piggyback lenses with putting the RGP on top of a soft. There's hybrid lenses out there and others. The thing with all of these is there's variability in how effective they are, how comfortable they are, and still assuming that the patient can get a contact lens in the eye. Scleral contact lenses, in my practice, has become basically synonymous with keratoconus. This vaults over the entire cornea. It makes it so that there should be minimal to no touch at any point. The comfort should be quite a bit higher. Vision's more consistent and more stable. Comfort we expect to be a bit better again than some of these other specialty lenses. But it can be challenging for patients to get them in because of the size of the lens. And it's still a contact lens where not everyone is happy with this. And we'll talk more about this in just a little bit. All of these options we've discussed so far are correcting vision. They're not as much focusing, for the most part, on preventing the progression of the keratoconus. These are trying to help patients visually and get over a lot of the struggles that they're having. When we start getting into more of the solutions for stabilizing the keratoconus, I would say the most common one out there that we're running into is corneal cross-linking. For those that are not familiar with corneal cross-linking, this is where we're going to remove the epithelium. We're going to instill riboflavin, and by putting that into the eye and then exposing it to UVA light, then that riboflavin is going to go through a chemical reaction where it's going to create bonds between the molecules and the fibers of the cornea. That is going to strengthen and stiffen the cornea. By increasing the diameter of the collagen fibers, it's going to stabilize the keratoconus, slow down, or even stop the progression. It flattens out the cornea, and again, looking visually, it reduces the aberrations, should improve the acuity and hopefully the quality of life. However, the vision results are variable. There are patients that will go through corneal cross-linking and actually have reduced visual acuity from before. And so this is again, while it's a great procedure for stabilizing the keratoconus. It also is something that, we're still trying to perfect and trying to find new ways to make it even better. And of course, there's other things out there. Here is basically a summary of what we just talked about, where we're talking about debriding the epithelium, adding in the riboflavin, and going through the UV exposure. Essentially, this is again going to strengthen the fibers of the cornea and prevent the keratoconus from progressing. Now, there are some refractive surgeries out there that we can do for visual improvement. Of course, when you're talking to a patient and we talk about refractive surgery, the first thing we say is LASIK. Why do we not want to do LASIK on a keratoconus patient? It's not just because the cornea itself is thinner, it's also because of that flap. Again, these patients tend to rub their eyes quite a bit, and the last thing we want is to ruin the flap with the keratoconus cornea, where it's going to be conical, where it's going to be potentially rubbed quite a bit. And so this is something that very much is contraindicated for a few different reasons in our keratoconus patients. A lot of times we're going to go into some options that are out there for refractive surgeries, ICL, an implantable contact lens. It is safer than LASIK. It does improve vision a little bit more than glasses and contacts. And then PRK, there are studies out there that have showed doing PRK on patients with keratoconus. This is going to be a little bit safer than LASIK because we don't have to worry about the flap. And it's also reshaping the stroma, which is going to be a little more stable and less risk of thinning the cornea like LASIK does. So there are some evidence of these refractive surgeries actually helping in our keratoconus patients. However, that leads us to the intact ring, some of the more invasive procedures where intact specifically is going to be PMMA pieces, plastic pieces inserted into the stroma. And these big pieces are used to flatten out the cornea. And that basically strengthens it, solidifies it, it flattens it. And this is again reserved more on the mild to moderate range for keratoconus. It can't be used if there's been too much corneal ectasia. But with this procedure, we expect that there an improvement in acuity, reduced aberrations because we're having a little more control over the shape of the cornea. This can be used in conjunction with corneal cross-linking to help with the visual results from it. And again, there is some variability to it, but this is something that's on top of the corneal cross-linking, especially to stop the progression of keratoconus, to help with the vision complaints that patients may still be having. The more extreme solutions are the corneal transplants. And with the corneal transplants, we're basically trying to replace the diseased tissue with donor tissue. And this should improve vision, reduce a lot of the pain that can happen in more severe keratoconus. And the full-on replacement, the full thickness replacement of corneal tissue when the entire cornea is severely damaged enough that we have to replace the whole thing. That is a penetrating keratoplasty. The PK, again, all layers of the cornea are affected here. You can see in our picture that it's going from front to back and is all donor tissue sutured in there. For situations that are a little bit less extreme, where we're only targeting the diseased parts of the cornea, you can do lamellar keratoplasty. Most commonly is the deep anterior lamellar keratoplasty, which is really replacing the front portion and the middle portions of the cornea. That's the part that's been, diseased, and so because it is a partial transplant, it does lead to less rejection, and will also result in a faster recovery than a full penetrating keratoplasty. There are some newer options out there, some artificial and synthetic implants, the Corneat and the EndoArt. That's where we're actually getting some uh, synthetic tissue that and basically implanting that into the cornea instead of relying on donor tissue. A lot of times these will have even lower rejection rates, but this is still very new, and we're still seeing what the long-term results are. These are still going through a lot of trials, but you may start seeing these pop up in the near future. So I'm not bashing any of these options. These are absolutely very, very significant for a lot of patients with keratoconus. But there are limitations to what we can do with these patients, and certain expectations we're trying to make sure that patients are aware of, so that we're not over-promising and under-delivering. When we're going to the early stages and we're speaking on glasses and soft contact lenses, we're basically telling them that their best corrected visual acuity may still be reduced. It's going to change over time. That irregular corneal astigmatism is still going to be causing some visual effects, distortion, higher aberrations, coma. They're still going to have symptoms. They're not going to have that perfect, clean 20/20 vision. And even if they do see 20/20, many times they're going to have reduced contrast sensitivity or other irregular complaints. We expect the keratoconus may get worse, and as that happens, the refractive error changes. Their prescription will change quite a bit over time, and sometimes it can worsen very rapidly. Patients who are going through glasses and soft contact lenses, again, these patients in their early to mid 20s can become very frustrated with their quality of vision and their quality of life because they're just simply wearing glasses and contacts like they should, and their eyes just continue to get worse and worse and worse. And then when we look at the specialty contact lenses, we're talking about, again, the RGP, the Rose K, piggybacks, etc. Typically, you're going to have a lot better vision. Some of them are not quite as comfortable for patients, especially when these patients have a low tolerance for contact lenses because of their eye sensitivity. There is a certain amount of maintenance and upkeep that patients are expected to have. And that, like we were talking about before with the depression slides, it can be very stressful and reduce their quality of life to have to rely on these types of contact lenses in their everyday life. Sclerotic contact lenses, again, synonymous in my practice with keratoconus, while it's still great at improving comfort and stability, is still only possible for the contact lens patients that can tolerate it. And for intolerant patients, it still leaves us wanting more. They can be expensive. They can still be high maintenance. And so we, have to, take these patients and with those kind of, concerns, wait until we get into the surgical procedures. Corneal cross-linking, being very effective at preventing the progression of keratoconus, may improve acuity, but like we mentioned before, it is highly variable. You can still have reduced best corrected visual acuity. You may still need glasses or still may need contacts even after getting the procedure done. Many of these patients will, have reduced vision in the same way that we were talking about before with contrast sensitivity with distortion. The side effects of this procedure, because we are removing the epithelium, it can be painful, it can be irritating and uncomfortable. There can be a risk of corneal haze and scarring that typically improves with time. Progression is still possible. It is still a surgery. The more extreme surgical options that are intended to slow or stop the progression and repair damaged tissue, they're not necessarily meant to improve vision to the same point that the lower severity patients are. The refractive surgeries will improve, vision on top of these surgeries. However, a lot of the refractive surgeries, like I mentioned before, are contraindicated in keratoconic patients just because of the shape of the cornea. Uh, so the risk in performing a lot of these refractive surgeries on patients who already have corneal ectasia could actually worsen the keratoconus instead of improving it. The intacs, relatively low risk on the surgical end of things, can still cause irritation if the PMMA is exposed. And there is a limit to how much acuity improvement and the quality of vision that we expect at the end of it. Once again, PRK refractive surgeries can be done, but it does increase the risk of scarring and thinning of the cornea when we do that. The more extreme end of the surgical options, the keratoplasties, penetrating keratoplasty, the lamellar keratoplasties, when we're doing a full transplant, it's a lot higher risk of rejection, a lot higher risk of infection, a longer healing time. And keeping in mind, we're saving this for patients that are very severe. They're coming from very diseased corneas that are very scarred. There's a lot of distortion right there. These patients already have very, very low visual expectations from this. And so, really, any improvement is a major improvement when we're talking about getting to a penetrating keratoplasty. Lamellar keratoplasty, less risks than the penetrating keratoplasty, but it is still a significant surgery. It still has a lot of the same complications, though a little bit lesser scale. We still will likely have some sort of reduced vision and will likely still require other interventions, whether that be scleral contact lenses or at least spectacle correction to end it with the irregular astigmatism that we expect from this. Now, again, I'm not bashing these surgeries. These are extremely important and life-changing for some patients, but there is this imbalance where we're talking about the glasses and the soft contacts helping with the vision, but then having to abandon the visual improvement for stopping the progression. And then once we've stopped the progression, it's very difficult to go back and correct for the vision. And so this back and forth, this balancing act, you can definitely imagine how a patient in their mid 20s having to deal with the stress of this back and forth and these choices and decisions can lead to a lower quality of life, anxiety, depression. It's very easy to see how that can impact a patient's life significantly. And so, a really big problem here with patients, again, going to the ones that can't wear contacts, anywhere from 18 to 31% of keratoconus patients are intolerant of contact lenses because of the maintenance, because of the stress, because of the discomfort, in fact, risk of infection. And even the scleral contact lenses, which, again, even in my practice, are something that we do all the time for our keratoconus patients typically does not leave everyone with perfect vision. Only about 75 to 85% having a best corrected visual acuity of 20/25 or better. And so we're really lowering the bar from the rest of our patients and creating this expectation for them that their vision is going to be permanently affected for the rest of their lives. And a lot of these patients may not be good candidates for surgical options. There may be contraindications, or they just might not be bad enough to warrant the risk of doing a keratoplasty or even a corneal cross-linking in some of these cases. So these patients are left in this limbo of their vision worsening, wanting to do things to help, but they can't wear contacts, so they can't get into sclerals. Their vision is still reduced, but they're not ready for surgery. And when they do surgery, there's all the other side effects. It's this snowball effect where it doesn't seem like there's a winning solution. Because of this, because of all this balancing between contacts and surgeries, a lot of patients just simply resort to glasses, especially for the mild cases. And we're just telling them to deal with their reduced vision until their eyes worsen, when they can be basically treated with the surgical options. And a lot of these patients end up looking forward to surgery, which, is unfortunate, with all of the risks that are associated with it. And so, when we're talking about having to, get these patients to surgery, we're hoping their vision gets worse, and they're still going to have visual complaints. There's still the risk of surgical complications. It's something that we're really looking at. What is the future of keratoconus management to take better care of these patients? So, what do we have coming soon? A few technologies out there. The CX lens. This is a really cool lens because this is effectively a scleral contact lens that has a self-emitting UVA abilities built within it. And so when you fill it with riboflavin, you can actually put this directly on the eye. And there's an ultrasound biosensor that actually monitors how the crosslinks are happening. And so we can measure in real time how the cornea is stiffening. That's a lot right there. Basically, that's allowing us to have a lot more precise control of how the cornea is changing, of how the prescription at the end of this procedure is going to be. We're hoping that because of the variability that can occur with corneal cross-linking visually at the end of the procedure, that patients will have better or reduced refractive errors because of this more immediate control that we have during the process by having this biosensor attached to the contact lens. It's still going through FDA trials. But this is going to be a very interesting thing to manage, to monitor over time, because not only will it help with slowing and reducing the progression of keratoconus, but will hopefully leave the patient in a better refractive state at the end of it. There's a lot of discussion going on right now between is it better to go epi on or epi off, meaning the epithelium. With the corneal cross-linking, like I mentioned before, typically you're debriding the epithelium prior to putting in the riboflavin. But that, of course, leads to slower healing, more discomfort, infection, scarring. It's just uncomfortable. It's not a pleasant process. And so we're looking more at these epi-on treatments to basically allow the cornea to have a little more stability and healing time. And it's been very promising so far. But there's different ways to do it. There's some devices out there that are trying to supplement oxygen to the cornea to allow it to basically get the riboflavin through. Or there's whole new formulations of the riboflavin that are trying to allow better penetration into the cornea even with the epithelium in place. Still trying to, find a perfect solution here, but there are some good products that are in development that look like they will help with the healing process and reduce the amount of variation in the corneal shape at the end of this because the cornea does not, or the epithelium does not need to regrow. There are different lasers that are being used to reshape the cornea both before and after the corneal cross-linking to enhance the visual results. We already mentioned PRK is one that's been used traditionally, but there's a few other lasers out there, the Trek and the TCAT, that are trying to do similar types of things, more specific to keratoconus, to create some stabilization on the cornea and give more control over the final refractive state of the patient. CARES is another newer one, corneal allogenic intrastromal ring segments. This is going to be very similar sounding to the Intacs. However, instead of putting in a piece of plastic, a PMA tissue, we're actually putting in a piece of donor corneal tissue. This is not a full corneal transplant. This is just inserting the donor tissue, as you can see here in the picture, where there is some tissue actually put in the stroma of the cornea. This is done not in just one big piece, but in multiple small pieces that can be customized into different shapes and thicknesses. And that theoretically should give us basically full customization on what the resulting corneal shape will be, and theoretically give us the ability to control the patient's refractive error. And every patient that has CARES segments is going to basically have a fully customized treatment because of the customization between all the different pieces. A lot of times you can do corneal cross-linking after insertion of the tissue still to help control the progression of the keratoconus. And there are some other variation of CARES. The CACXL and the CTAC are some variation in doing a very similar process. So a lot of these, they're still being researched, are looking for FDA approval. They're needing to be refined and perfected and used in conjunction with each other. A lot of them still require either surgery or contact lenses. And so we want to keep in mind that there are some patients out there that this still may not be, good candidates for any of these options that are even upcoming. And even at the end of all of it, even with all the efforts, we still have an expectation that the visual acuity and the quality of vision may not be adequate for these patients and what they want in their lifestyles. And so we're looking, is there anything else? And so here I'm going to totally switch gears and start talking about perceptual learning. Perceptual learning is going to be teaching a different part of the visual system to contribute and help clean up some of these higher order aberrations and distortions. So talking first about cortical plasticity, I'm going to get very general for a little bit. When you're talking about vision, we can group vision into basically two parts. All right. Part one, we'll call it the front part, is the eyeball. This is going to be all the anatomical structures of the eye, the lens from cataracts. This is going to be talking about refractive error with how long, short, or shape of the cornea. This is the state of the retina for macular degeneration, diabetes. And so all of this is the front part of the eye. It results in an image going onto the retina. But then we have the back part. And the back part, a lot of times we don't think about, but it's the brain. The brain receives that information from the retina and it processes it and basically tells us what we see. And us as eye care practitioners, we are extremely good at focusing on the front part. We're great at being able to bend lights in certain patterns to correct for refractive errors, and we're great at restoring eye anatomy and through surgical intervention, through pharmaceutical intervention, to basically help patients get a better quality image on the retina. However, uh, can we focus on part two? Is there anything that we can do to help with the visual processing, the brain part of this? And right here, before we get too far along, weren't we always taught that the brain stops developing in childhood, typically around 7, 8 years old? The answer is yes, mostly. Here's a study that was done on cortical plasticity in individuals over the age of 11. Every single one of these patients had amblyopia in one eye with no other disorder on that amblyopic eye. These individuals lost vision in their good eye and were left with only their amblyopic eye. And in many of these cases, they did full occlusion, and 10% actually had significantly improved vision in the amblyopic eye. If development was truly done, then we would not expect any improvement whatsoever. And so this gave us some hope that there is some limited neuroplasticity even in adults. This is inconsistent. This is something that even with full, patching still had some variable results, but we still did have some improvement on patients. Now, here's another study where they took different age groups, and they took group A with basically treatment of wearing glasses or contacts while also doing patching and doing near activities. And within the older group, we had a subdivision of some that were treated with patching in the past and some that had never been treated before. And what's interesting here is you're looking at the improvements in the treatment group, the group A, where they did occlusion, the patching, they actually had an improvement in vision in every single one. However, looking at the 7 to 12-year-olds compared to the 13 to 17-year-olds, they actually had very, very similar results. Where the patching contribution was actually led to 28% greater improvement in vision in Group A over Group B. And so that again tells us that there's some plasticity to these patients that we expected to be outside of the range of improvement for amblyopia. So what is perceptual learning? We'll get more into it in just a little bit, but essentially it's repetitive exposure to a stimulus. And when we're giving this stimulus to a very specific neuron, we can improve the neurological function in that neuron, even in adults. And so we have several studies here with perceptual learning where we've been able to show in adults an improvement in vision and in contrast sensitivity and just visual comfort all around. And so, how does this actually work? Getting a little bit more into the nitty-gritties of this, starting with a visual cortex experiment done on cats once upon a time, we actually found that the cortical neurons do react to a very specific stimulus based on their location, based on their orientation, based on their size and spatial frequency. And when you're talking about vision and image as a whole, you're talking about all of these neurons that are each basically having one job responsibility, being used in conjunction and cooperative manner to create the image that we see. So it's a collection of neurons at different contrast sensitivities, spatial frequencies, orientations that are giving us the images that we process. And what we found was what this Dennis Gabor found was basically the size of the neuron that has an on-off activation, where if you're able to line up a stimulus in these horizontal lines or vertical lines in an alternating pattern of a certain size, that you're going to trigger a neuronal reaction. And so we call this the Gabor patch. Um, it basically gives us the highest neuronal response to a visual stimulus because the shape of that Gabor patch matches the receptive field of the neuron in the visual cortex. And so it's a one-to-one match. Again, knowing that we're focusing on one very specific orientation at a time, we're basically seeing that we can match the stimulus with what the neuron's responsibility is. And so during this, we're seeing that, giving a higher contrast target will give a larger neuronal response. That's something that should hopefully make pretty good sense. But looking at some of the different adjustments that we can make to these Gabor patches, different spatial frequencies, different orientations, different contrasts, different combinations and orientations of everything, actually have very, very different stimuli. And so every different target has a different goal. Every single Gabor patch matches a neuron made to identify a very specific stimulus. And so knowing that we can identify the stimulus of a certain size, shape, and location, what happens when we put things nearby? We get this visual crowding effect. And so we can get this visual crowding is when we take a known object, but we surround it with a bunch of noise, we lose track of that object, and it becomes very difficult to identify it. The neurons do not see it when there is too much noise, and so we're focusing on this signal to noise ratio and allowing the neuron to see the stimulus. And so, with visual crowding, when done in certain orientations, we found that it can suppress cortical cells or it can facilitate responses. It can enhance, facilitate the neural response. And so, when knowing that we have the Gabor patch that has a very specific stimulus that we're trying to trigger within the brain, they found that putting flankers on either side of it to create that noise can actually help to uh, basically push the neuron to get better at identifying that stimulus. And we end up finding that the flankers, facilitate or can suppress the response depending on where we're going. Going back to the study where they start adding the flankers, you can see that there is a difference in how the neural response was being seen. This is really the summary slide that summarizes what we just were talking about. They found that with the Gabor patch being shown as a stimulus to a specific neuron, that there was a neural response to that Gabor patch. If you just put flankers, just high contrast targets as noise, there was almost no response. But if you actually put a Gabor patch with a reduced contrast sensitivity or reduced contrast surrounded by flankers, then you actually got the highest neural response by having the brain effectively trying to identify that in the midst of the visual crowding. So, putting this into a one sentence thing, we're basically banging with a huge hammer on a small nail repeatedly until something gets fixed. In this, well, let's go ahead and say the huge hammer is the Gabor patches with the flankers, and the small nail is a deficient neuron. The more that we bang these deficient neurons with these Gabor patches and flankers, we can actually improve the neuronal response. We can teach the brain to identify that specific stimulus better. And if we do that for multiple stimuli in the visual cortex, that should improve vision all around. So this repetition stimulates the neurons and promotes the interactions between the neurons. Again, this is a cooperative process between all the neurons. At the end of it, we're improving the signal to noise ratio. We're able to teach these neurons that can't work as well and teach them how to identify signals more efficiently and effectively. This is the basis of what improves contrast sensitivity, the ability to distinguish fine details. As a side effect of improving contrast sensitivity, we are also going to improve visual acuity. If we can see finer details, then we're going to be able to identify smaller letters. And if we have, improved acuity in one or both eyes, we're better at using the eyes together, which then improves stereo acuity. That's a lot of information with a summary, but we do have studies to support this. This right here is showing adult amblyopia, age 9 to 55, patients outside of the window of visual development. And we're looking at their basically mean best corrected visual acuity in the amblyopic eye about 20/50 in both the treatment group and the placebo group. But then after going through this perceptual learning, they treatment group actually improved their acuity down to 20/30, while the placebo group was stayed at 20/50. What is also interesting is a year later, we had very stable results in those amblyopic eyes. By hammering those neurons repeatedly, by teaching the brain how to see these stimuli, more efficiently and effectively, it's actually improving these patients' acuity. And so right here is a summary of that. We see that the best corrected visual acuity at the start of the treatment is the red line, hanging around 20/50 for a visual acuity, but at all spatial frequencies, it is reduced. At the end of the treatment, the patients on every single spatial frequency had better contrast sensitivity by 100%, and their acuity was improving by multiple lines up to 20/30. And then even more impressive at the end of 12 months, that the contrast sensitivity actually shows improvement while the acuity is effectively the same. In this study with all the patients, you can see the different types of amblyopes that we were looking at, the anisometropic amblyopes, the strabismic, and then combined monofixations. All of them showed consistent results of at least two to 2.5 lines of acuity improvements. And even more impressive, looking at the age, this thing that we've kind of told ourselves that we cannot improve patients at this after a certain age. We had the same visual acuity improvement in an amblyopic eye by doing this repeated visual stimulus. Right here, again, as we improve contrast sensitivity, as we improve acuity, we are also going to improve the stereo acuity. And so again, these patients, showing before and after an improved stereopsis. Binocular functions, once again, at the end of the treatment, many patients all of a sudden were able to fuse. There's a lot of studies out there that support perceptual learning. And the thing that I like to, point out is with the amount of studies, with the amount of ages, with the amount of types of things they were looking at, we have consistency in the acuity improvement between 2 to 3 lines of improvement and a consistent improvement in contrast sensitivity as well. Looking at how consistent these results are is very, very, very promising for our patients in knowing that we can improve something. This is actually a study showing a 5-year follow-up to the training. This just came out this year, where in these patients, again, 89 subjects, 20/70 on average at the beginning, pre-treatment. And then after 5 years, we're still showing a 20/40 acuity. After 5 years of doing this, this is not something where they had to continue doing this training consistently. They did this for approximately 2 to 3 months and had stable results for the entire time. And so, what is the process? What is perceptual learning from the patient side of things? Basically, it is a program. It starts with getting a standard comprehensive exam where we get information that we need to establish the program. The information that we need are, the normal things, visual acuity and is there a aphoria? What's the depth perception? Is there a stereo acuity? The kinds of things that a lot of times we can very easily check within a standard comprehensive exam. And then identifying the goal with a patient. What are we trying to accomplish? What's the etiology? Are we dealing with amblyopia? Are we dealing with keratoconus? Or are we dealing with something else? Is that can adjust the program internally. And then going through the program, again, looking at the different things, acuities, refraction, binocularity, contrast sensitivity, if you're able to, within your exam lane, can be very effective baseline measurements for what we're looking at through the training. The training itself is something that can be prescribed by eye care professionals, performed at home. And it's basically about 30 minutes is what was done in the studies, 30, 40 minutes, 3 times per week. And you do this for about 30 to 40 sessions. At the end of 40 sessions, that was considered to be the end of the training for all of the studies. And this is done at the patient's own home. And so the treatment flow, being 40 sessions, 30 minutes each, 3 to 4 sessions per week. Information during the testing is basically constantly being sent to the manager of the program, us, the doctors, and it's also able to adjust. It is a smart program that as patients are getting more answers, correct during the training process, the stimuli become more difficult to identify, which is again pushing the neuronal response to improve. And so it's a smart feedback loop. Checking the vision regularly allows us to see the improvements in these patients. Again, allowing us to monitor the progress itself. And the acuity does reach a plateau typically at that 40 sessions. This is not something that is shown to continue, indefinitely. There is a plateau to it, but at that 40 sessions, we get improvement in a lot of different things. This is a short video of what this actually looks like to the patient. Bear with me here.
Each triple image task is made of a pair of displays. One display has 2 images in it, while the other has 3 images. Your task is to find and choose the triple image, the one with the 3 images. If the triple image appears in the first display, you should click the left button. If it appears in the second display, you should click the right button. If you can't tell in which display the triple image was shown, just guess. The images may appear in different sizes and directions. No matter what the size and direction are, the task stays the same. Identify the display with the 3 images.
And so you can see how we have multiple orientations and multiple type of tests, the utilization of the flankers, being able to promote the neuronal activity in very specific parts of the visual cortex. This is what a resulting session looks like after the patient has gone through 40 plus sessions. And this can be a little bit messy to observe, but we can see that the stimulus size decreased over time in the eye that is represented by the blue line. Um, and that the visual threshold, the lower on the graph you are, the better vision, how we're getting this generalized improvement in vision. And this is, of course, on a keratoconus patient. And so looking at the benefits of doing what perceptual learning, it can be a home-based therapy where a patient does not have to go to a surgical center, does not have to go to a doctor's office. They can actually do this in office or in their own home, resulting in minimal office time from the practitioners. There's no side effects, there's no medications, there's no surgical complications to this. This is simply brain training. There is a low cost because there's no equipment, no device footprints, no materials or surgical procedures required for this outside of just the program itself. And the long-term efficacy has been shown to be up to 5 years, and it can be used with other therapies for vision improvements. This is again only treating the back part. This is the brain. We can still do everything we've always been doing to improve the front part of vision, the eyeball portion. This is only enhancing what everything else has been done after everything on the front has been exhausted. So this is just quite simply what I tell my patients is brain training. At the end of it, these are the outcomes that we expect. After all the data, after all the information, we're expecting about a 100% improvement in contrast sensitivity. We're expecting about a 2.5 line of visual acuity improvement, and which leads to an improvement in stereopsis. Again, these patients who have already exhausted their limitations in what we've been able to do on the eye portion of it. This has taken a blurred image on the retina at 2040 and improving it to 2020. So this is something that opens up a lot of possibilities for us. So now let's combine where we're going back to keratoconus. What can we do to help keratoconus patients' vision and to make their lives better? Going back to where we were before, many are unable, even after treatment, to reach 20/20 vision. Many of them have reduced contrast sensitivity, quality of vision, significant distortion, etc. Many of these are going to have reduced stereopsis because of the keratoconus and the monocular or unilateral findings that we have, the imbalance findings. And that leads, of course, to the poor quality of life, which we all became doctors to improve the patient's quality of life. And so now looking at some studies, this happening in just this year, January of 2025, in keratoconus patients trained with perceptual learning in a trial. Right here, we're seeing that the visual acuity improvements was a couple of lines. We're seeing stereo acuity improving by about 47%. We're seeing an improvement in contrast sensitivity, in all parts compared to the placebo group. The point 0.2 logmar is about 2.5 lines of improvement. In this, basically, we're seeing a study done on patients that already had stable keratoconus after corneal cross-linking. And these patients had an average best corrected visual acuity baseline of 20/40 or worse. They went through the 40 home training sessions over the course of a 3-month period with an average improvement of 2.5 visual acuity lines and a significant improvement in contrast sensitivity. This is not a replacement for corneal cross-linking. Corneal cross-linking was still done to reduce the progression of keratoconus, but this was simply done to improve the vision afterwards without any sort of risk like the refractive surgeries or forcing the patients to go back into, scleral contact lenses, etc. Again, a 2.5 line of acuity improvement in these patients. This is another study right here, which is again 2.5 lines of improvements. Or actually, this is just another study done 2025. It was 300% improvement in contrast sensitivity, 2.8 line improvement near acuity, 2.5 line improvement in the distance acuity. This is something that a lot of us would love our patients to have. This is just showing the same information, just in a slightly different way, showing the consistency between the eyes in both the distance and the near acuities. And so when we're looking at keratoconus patients, looking at the visual complaints that they could have with the acuities not being reaching 20/20, the contrast sensitivity, the stereopsis, the quality of life, we're hoping that with the perceptual learning, we've been able to improve all of these things. There's no worries of contact lens sensitivity or surgical risk or complications from this. A few quick other applications of perceptual learning is, of course, basically from all these studies. And we have about 30 studies out there that we can find with perceptual learning, all these controlled ones. We have adult amblyopia, which we've already touched on, where there's a lot of studies support. It's actually FDA approved for amblyopia in the United States over the age of 9. It's the only technology that has that. This is the original intended application of the perceptual learning. There's actually evidence of refractive conditions that can be improved by a diopter. So your low myopes, early presbyopes, even post-LASIK patients can have visual improvement as well. Other ocular disease, again, addressing the back part when the front part can't do the job. There's studies on macular degeneration, retinitis pigmentosa, and congenital nystagmus being improved from perceptual learning. And theoretically, any condition where we have blurred retinal image can be improved from this. And there's patients who want to improve quality of vision with multifocal IOLs, reduce contrast sensitivity from contact lens wear, just general patients that you see every single day. And there's even patients that you can consider doing this when they want better visual performance for sports activities, etc. And so while current treatment options for keratoconus really emphasizing reducing the progression, the visual improvements, while is important, has been variable and sometimes limited. And with perceptual learning, it allows us to address a part of the vision that we've not addressed in the past with the brain. It can be used alongside other treatments to improve the visual and basically results in patients. And I hope that's something that we can lead to improving our patients' quality of life. And as optometrists, I know that we have an opportunity to improve patients' quality of lives. And I think that with perceptual learning, you're going to see more about this, how we're going to be able to educate patients and give this as an option when we had normally exhausted all of our other options.